This is the Whole Care Network. Helping you tell your story one podcast at a time. Content presented in the following podcast is for information purposes only. Views and opinions expressed in this podcast are solely those of the host and guest and may not represent the views and opinions of the Whole Care Network. Always consult with your physician for any medical advice, and always consult with your attorney for any legal advice. And thank you for listening to the Whole Care Network.
As much as we hate talking about death, we can all acknowledge that death is inevitable and we will experience it. But so many people can easily convince themselves that they're not going to have to deal with caregiving or aging or all these other issues. It's just, for whatever reason, it's easy to convince themselves of that. But that's increasingly becoming not the case. Most people are going to have to deal with these issues at some point because we're aging. Chronic disease is extremely prevalent. It's not going away. So these problems are only going to become bigger.
This is the Heart of Hospice podcast with Helen Bauer. My guest today is Jacob Kendall of Demystifying Healthcare, a social worker, educator, and advocate for patients and caregivers. Whether you're a family caregiver or an end-of-life professional, the Heart of Hospice podcast is here to enhance your hospice experience by connecting you with information you can use about end-of-life care.
This episode is sponsored by GrandPad. GrandPad is the all-in-one tablet designed especially for senior adults. With GrandPad, you get safe, simple video calling and photo sharing. Users can create a private family network that allows for secure photo and video sharing. The GrandPad utilizes a simple format that allows seniors to enjoy games, music, email, and more. Visit our special GrandPad website designed exclusively for the Heart of Hospice listeners at grandpad.net/THOH.
My guest today is Dr. Jacob Kendall. He is working to demystify healthcare. He's the survivor of 2 open heart surgeries in early adulthood, and he has formal training in gerontology, public health, social work, biology, and theology. Jacob has a doctorate of philosophy in interdisciplinary aging studies, a master of public health, a master of social work, and a BA in biology. He believes the key to mastering health and being a savvy patient or caregiver is a convergent 4-dimensional approach, integrating multiple perspectives to show that health and healthcare are more than individualistic. This guy gave me a run for my money when it comes to my intellect. He's got a well-rounded background in education and healthcare that allows him to be a really strong advocate for healthcare consumers. Our discussion revolved around the current system of healthcare and why advocacy is so necessary inside the systems we're having to access. Jacob provided a 4-dimensional view of healthcare and how those dimensions affect the way we receive the healthcare we get. He also shared ways that you can communicate with your healthcare team and be your own advocate in a way that's productive. You can connect with Jacob on his website, jacobevanskendall.com, and on LinkedIn as well, Jacob Evans Kendall. And check the show notes. You'll be able to find the website and the link to his LinkedIn account as well. So put your thinking cap on because this interview is going to make you think. Here's my conversation with Jacob Kendall. Jacob, welcome to the Heart of Hospice podcast. It's great to have you on the show.
Yeah, Helen, I'm glad to, looking forward to having a discussion with you, and I'm thankful to be here.
It's going to be good. So I'm going to get us started with an icebreaker question that I didn't send you because I like to sneak these in. So this is actually my favorite icebreaker question. Nobody ever asks me this, but I would like it. If you were king of the world, if you were in charge of everything, name 3 people that you would have as your advisors.
Oh, famous people or people that...
Could be people that are dead or alive, famous, not famous, totally anybody you want to think of. They could even be imaginary for that matter.
Okay. Probably my brother. He and I get along very, very well. He's super creative.
Nice.
I'm a huge Alabama fan, and I think Nick Saban's the greatest college football coach of all time, and he's got thousands of times more discipline than I do, so that would be a good person to have around. Um, wow. I'm trying to think of someone imaginary. Uh, this is a really interesting. I have my favorite icebreaker questions too. I'll think on that third one. I feel like I should choose imaginary one because I want to complete the category. I choose someone personal, someone famous who I've never met, and I'll think on a fictional example. That's a good question.
I like that. Just kind of a well-rounded group. So if I said Roll Tide, that has a lot of meaning for you, doesn't it?
It has a whole lot of meaning. Yeah, I might choose someone off of Bartlett's team in The West Wing, or maybe Bartlett himself.
Oh, interesting. A character from a TV show. Nice.
Yeah.
There were a lot of characters from that show from West Wing that were pretty amazing people. So yeah, I like it.
Yeah.
That's a good group. One of these days, somebody's going to ask me that question, and I'm going to have to come up with something good. I like that one.
I'm happy to ask you now, but I don't know if you want to take the time to.
No. This is all about you. Today is all about you. So let's dig in. We're going to try to take the next 45 minutes or so to demystify healthcare, as it were. So your background is very interesting. You've got a blend of being a healthcare consumer yourself with your own healthcare background. You've been a family caregiver for your family members and working in healthcare as well. So what compelled you to start demystifying healthcare and become such an outspoken advocate?
Yeah, for sure. And I'll revise what you just said slightly, because I think a lot of people, when they say I've worked in healthcare, they'll think I've been a clinician. I don't really have much clinical experience, but I would say that I am a healthcare professional at higher levels of healthcare.
Right.
And so that's the first thing I'll say. There are two parts of my identity that are very informative for why I do what I do and very impactful for me. And one of them is the interdisciplinary nature of my training, of my worldview, and the way that I approach any problem, including healthcare. My PhD in gerontology is technically in interdisciplinary aging studies, and that's way too many syllables, so I just say gerontology. And we learned about aging from the perspective of any discipline you can think of: cell biology, genetics, cognitive neuroscience, anthropology, epidemiology, law, architecture, engineering. And that's how I prefer to be truly interdisciplinary. I'm still looking for a good term that applies outside of academia, because interdisciplinary is kind of insulated within academia where I was raised. Maybe interprofessional, multidimensional, some things like that, but basically viewing and approaching any problem from multiple perspectives. And I absolutely think it's critical that we need that with healthcare right now. And the other part of my identity is my own complex medical needs. I've had 2 open heart surgeries. I have lifelong experience navigating my own medical care and complex needs, and helping family members do that as well. And, with our inefficient healthcare system, push came to shove, and I'm shoving back. And so those two things intersect in a place where I want to do more chronic disease. I do chronic disease advocacy, thought leadership, and aging caregiving, dying and death, where all these different things intersect, and especially bringing in a more macro perspective. We're so individualistic in our society. I think American individualism is running amok. And so we need these more macro public health global perspectives in order to really address these issues well.
And we've got what I think of as this apples to oranges not comparison, but an apples and orange system. We have a system that's supposed to take care of human beings. We have an industry designed to manage end-of-life care and death needs for people. It doesn't really seem to go together. Yeah, it's at odds. And so as a result, we've got all this great technology that we are now having to unlearn to be able to care for people at end of life. And I think having somebody who's an advocate like you are for people to be empowered and be educated and be advocates for themselves inside their own healthcare needs it's never been more needed than it is now.
Yeah, and I probably would revise what you said. You said we have a system that's supposed to help, something like that. I don't know that our healthcare system is designed to. I don't think it's supposed to. The people who are in control of it at the very top benefit from Americans being sick. They benefit from, we spend an inordinate amount of money on the last 2, 3, 4, 5 years of life because of testing. Most people don't die in their, or a large percentage of people don't die in their own homes. They're hooked up to things at the hospital. That's not what we want, but that's where we are. And there's a huge incentive for uh, healthcare providers to do all the things that they do to people in their last days. And I think there's a trickle down effect from that. One of my favorite quotes, and I keep on telling myself I'm going to look it back up. Um, it was a British prime minister, I think, from several decades ago, William something, but he has this quote, and I'm paraphrasing, but he's like, something like, you show me the ways in which a society treats its dead, those of the bodies who have already died, and I will be able to tell you with statistical exactitude the level of compassion that society has for all of human life, for all of life. And so basically, the way that we treat the dead is a reflection of how we treat all of life at every stage. And I think that we can take one step back from that and say the way that we treat the dying is reflective of the compassion that we have in general. So I agree with you. There's a lot that we have to unlearn. I think that we really need to take a good, hard, long look at how we approach dying and death, and body disposition, all those things, funerals, etc., hospice, and all these just different things, that are tied into that, and work backwards from there. And I think that can be extremely informative.
Well, the conflict here, when you're talking about a system that's designed to take care of human beings, is really embodied in the fact that we have all these for-profit hospice agencies. It's an industry, it's a business. And yet, we're talking about managing people's spiritual health and their emotional health. Yeah, it doesn't really seem to go together. It's a machine designed to take care of human beings. So that's where I think that conflict comes in. And the healthcare system inside the United States, admittedly, it's broken, right? Everybody knows it. So being able to demystify healthcare, for people to understand what their healthcare should look like and how to ask for it, how to make the most of it. I think there are organizations that are fixing the healthcare system and working to try to fix it, reform, advocacy. But on a personal level, that's not going to happen overnight, and people are still dying every single day. So we have to learn to take care of ourselves within this crazy industry that we have across the United States. And I think that's why advocacy is so important. Self-education, connecting with somebody like you who's providing that support and that education. So one of the things that you teach when you're speaking and you're working with clients is that healthcare is four-dimensional. Healthcare is four-dimensional. What does that mean for you?
Yeah, admittedly, I'm still working on how to convey this idea fully within a single sitting. So I'll give a summary, and I've already hinted at one of those dimensions. If you think of physics and space-time, that's where the dimensions come from. We have 3 dimensions of space and 1 dimension of time. And I've already hinted at one of those, and that's different levels of analysis. It's so deeply embedded, like it's so deep in our marrow and our culture, that the individual person is the most important unit of analysis, that we miss the forest for the trees, kind of, so to speak. I think that in order to address these issues, we have to be able and willing and comfortable zooming out to higher levels. And let's look at not just the health of the individual, but the health of the family, right? The health of a neighborhood, the health of communities, of cities, of states, of nations. We have to be willing to say, you know what, there's some really important stuff going on at these other levels. I'll give you one example. It's one of my favorite to use is Oh, well, I don't want to support policies that help those with obesity because it's just their fault that they eat all that they eat too much. That is an individualistic notion. I've heard this. This is not an uncommon argument.
Right.
That's assuming that everything that's important about that issue happens at the individual level, and that's just not true. What you miss if you stay at the individual level is that there's the rates of obesity and stroke and diabetes and heart disease, et cetera, are much higher in areas where we have so-called food deserts, right? And it's usually tied to poverty as well. And so the only options they have for food within a geographic area are convenience stores and other places that have foods that are high in sodium. They're less expensive, but they're high in sodium, carbs, sugars, et cetera. And there's no individual level decision that these people can make to have access to better food. And so we can't possibly understand that unless we zoom out. And that's one dimension, right? Zooming in and zooming out to different levels. And we could talk about zooming in to levels smaller than the individual. We even have such things as cellular medicine and quantum medicine. I'm not going to get into that. Just suffice it to say, we need to be able to zoom in and zoom out, or we're not going to get the whole picture. I also we have to be able, this is where my interdisciplinary self comes in. You know, if you go to a university campus, they have the Department of Psychology, the Department of Biology, the Department of History, the Department of Religion. I just don't, why does it I have to all be separate? It's a really outdated notion that it has to be that way. It's the exact same way in medicine. You know, I have electrophysiologists, cardiologists, neurologists, pain doctor, physical therapists. Why does it necessarily have to be the case that they can't have better communication with one another? That there needs to be it should be more of a continuum of care, but that's not the way that it functions. Furthermore, medicine is not just healthcare is not just medical. I mean, I'm in a Facebook group of people who have had my same kind of heart surgery, a valve replacement, and we're on blood thinners. And I've learned just as much from insights from those people as I have from my doctors. I think this might be a little bit of a generational thing, I think. But I've heard a lot, especially from older adults in my life. Well, the doctor told you this. You should trust that. And I'm like,
I think
no.
that is generational. Absolutely.
Yeah, for sure. Like, no, my doctors are great, but they don't know everything. So that's the second dimension. It's not just medical, and we need other perspectives. And then there's the geographic component. That's the third dimension. And I'll give an example for where I live locally. I live in one of the fastest growing counties in the U.S. It's very rapid population growth. And when I first moved here 3 years ago, because I have complex medical needs, one of the first things I always do when I move to a place is establish myself with my providers really early on, earlier than my wife does, because she doesn't have my same complex needs, right? And
Sure.
so I got in with my primary care doc. She didn't try to get hers to a few months later, but mine had already shut her down her office to new patients. She could not accept any new patients. And when I first moved here, I'm like, man, these are long wait times, or I have to schedule my appointments months in advance. And it was easy for me to be upset about, frustrated with the doctors who were just taking on too many patients, but I started to connect the dots. You can't drive 5 minutes in any direction without seeing evidence of population growth here, because there's always neighborhoods and apartment complexes going up. And I'm like, you know what? I bet that is affecting access to healthcare here.
Yeah.
And I've told my wife straight up, listen, I've got to have these needs. I've got to be near a stroke certified hospital, et cetera. And I'm concerned about access to healthcare here in this area because of rapidly growing population. We don't have the infrastructure for it. So I'm like, we might need to have some backup cities ready. Like, let's start looking into it. What other cities have the healthcare needs that I have, but don't have that population growth? And that's another one, geography, right?
Right.
That's another one of the dimensions. And then there's the time dimension as well. An example with that is soon after we got married, I got we were like, okay, we need to get a life insurance policy. And I knew with my medical history that it was going to be hard finding someone who would insure me. But we found the company, and my wife's policy is much larger than mine, and it's much longer. Mine was 22 years. That was a couple years ago. So according to them, I have 20 years left. And so, obviously that's based on factors, and it doesn't account for every single variable. And I hope to make it well beyond 20 years. But you know how life insurance companies work. And so the time dimension is important as well. And relate that to caregiving. Americans are so horrible about planning for crises. We don't deal with crises until they hit. And it's really tough to convince people that they need to go ahead and like, hey, have conversations about what happens when you die. Um, and all these other things. We're just terrible about that. And so those are the four dimensions. Hopefully I summarized that pretty well.
You did. You did. So I would add on to what you said about people failing to plan for crisis moments. I think that as bad as we are at planning for our deaths, I think we're way worse at planning for caregiving situations. We may ask somebody, okay, do you want to be cremated? Do you want to be buried? Do you want to have a funeral or a memorial service, etc.? Do you have a will? But back up. Do you have somebody who can take care of you if you become bedbound? Do you have somebody who can allow you to live in your own home if you become so confused that you can't take care of yourself? I think we're actually even worse at having caregiver conversations than we are at having death conversations.
Yeah, for sure. That's what I meant when I said earlier, when I gave that quote from the British Prime Minister. I think we can take steps back from that and analyze, instead of analyzing life from birth to death, which that does have benefits. We should do that, but we also need to be analyzing it backward, and that's where you get to see like what you're saying. Where the waters get muddier and muddier and muddier the farther back that we go, and that should take us to the roots of the problem. As much as we hate talking about death, we can all acknowledge that death is inevitable and we will experience it. But so many people can easily convince themselves that they're not going to have to deal with caregiving or aging or all these other issues. It's just, for whatever reason, it's easy to convince themselves of that. But that's increasingly becoming not the case. Most people are going to have to deal with these issues at some point because we're aging. Chronic disease is extremely prevalent. It's not going away. So these problems are only going to become bigger.
Well, I think people a lot of times choose to ignore it, right? The denial part of things. And I think it's a very daunting thought. You're impacting emotional, psychological, maybe even spiritual issues, spiritual health and beliefs, things like that, and then the financial piece that comes with it. And then if you're looking at community, you're looking at relationships, people are actually choosing to become solo agers. They have family members that they're distant from or they can't rely on, and they choose not to do that. So that would probably be a whole nother podcast interview just by itself because there's so much of that. So I totally agree with you. I wanted to touch back on something you said about continuum of care. I think that is such a great term, but I don't think it describes what we have. I absolutely do not. As a hospice practitioner, I will tell you, going in as a hospice nurse and having families that have said, the doctor told us there's nothing else we can do. That's not a continuum. That is somebody who shut down that relationship and said, you have no further options and there's no hope. Oh, and now we're going to send you over to this other place. This hospice team is going to take care of you. And they wonder why people are so hesitant to engage in hospice care. I think the idea of a continuum is a fantasy. It's something we like to say, but we're so siloed. Like you were mentioning with all the different specialties that you have for your care. I think the continuum, it's actually not an accurate term for the system that we have.
Yeah, I agree. I hope I didn't convey that I think it is. I think it's an ideal to aspire to.
Yeah.
I'm not sure. I mean, I'm going to be really honest right now. There are many days when I feel very despondent about the state of our healthcare system. I mean, let's focus on the one dimension of zooming out, okay? I think that it can do most people good to zoom out a little bit. I just gave you the example of I live in a fast-growing county, and that's going to affect healthcare access, right? And I can't know that unless I zoom out a little bit and say, hey, there's something going on here at the population level. So it can help us, individuals and families and households who are going to have to face these issues of chronic disease, caregiving, et cetera. I think it can help most people to zoom out a little bit, at least. And when it comes to policymakers and public health professionals, zooming out a little bit more than that. But if you zoom out enough, you're eventually going to get to the people who run the medical industrial complex, the admins of health insurance companies, and you're going to hit a ceiling that cannot be broken through. These are intractable problems. And I think it's important for us to consider, where are the places where we can make a difference? And I definitely think at the individual level we can. Like I can sit here, you and I can sit here, and other people who are working with these issues. We can have conversations with persons and with families and make a difference. But we also need to have people who are working at higher levels than that. But again, there probably is that sweet spot, and if I personally believe there is no point in trying to convince millionaires to want to make less money. That's what this comes down to. That's what it comes down to.
That's true.
And it's not just hospice, it's not just healthcare that's a for-profit industry. Insurance is a for-profit industry. The pharmaceutical is. Home health care, senior living, retirement, life insurance. These are all for-profit industries in this country. And it would take convincing the people who lead them to want to make less money to solve them. I know I just got really negative, but I think it's important. It's important to know what our limitations are. Yeah.
Yeah. Okay. So let me ask you this. I'm going to push back a little bit. So when you're talking about zooming out, as far as an individual goes, right? Because those CEOs and the heads of those organizations, the larger, that's their job, right? To zoom out and look at a bigger picture, right? To know the state of the industry, the state of their company. But when you're talking about individuals, when you have somebody that's a caregiver, somebody living with a serious illness, how much energy do they actually have to pull back and say, I need to look at this a little bit bigger. I need to live somewhere where I know that there are enough physicians to manage the population so I don't have to wait 8 months to see a doctor. Is that a realistic ask for somebody who's an individual that may have limited education, finances, etc., limited choices? Is that a realistic ask or expectation of them?
Yeah, that's an excellent question for sure. And, I've been asked this question because I talk about four-dimensional thinking, and to some degree, that's an intellectual concept, and I enjoy talking about it. But we have to talk about pragmatism at the same time, right? I mean, a lot of these people that we're talking about helping are in a crisis situation, and they're like, I can't just solve this problem that's right in front of me. And so you ask a poignant question. I would probably say that a good route to go is to consider which of our professionals should have this kind of thinking in mind. I mean, I don't think it's reasonable to add more education onto med school or nursing school. They're already going to education and going into that enough. But let's take something like social work, right? Most social workers are working in case management, medical social work, school social work, mental health therapy. So they're way down on the micro level. That's where our field has gotten. I could go on a whole other soapbox about where I think that's a problem, but social work does technically have a macro component. And I did identify myself that way. With social workers, I typically say, I'm so macro, there should be a level above macro. And one of the questions that I ask is it reasonable? Because I think social work is it's having an identity crisis right now. One of the questions that I'm posing to the profession is, you have this macro piece, but you do macro very, very poorly. Either we need to step it up as a profession, or we just need to decide, okay, let's just stick to the micro. So I think that there are certain professions like that where we should be asking, should they be trying to work more on these policy macro levels, which is what we're seeing in fields like social work. Teaching is another one where they're leaving their fields because they realize, okay, to make these changes, we have to step into these more macro spheres. And, I think about people like area agencies on aging and other people who are there to provide these kind of resources for caregivers, their families, and the patients, and connecting them. They too are overworked, but should we be asking questions about giving more infrastructure to kind of address these more systemic issues? And I think it's probably going to have to come from some kind of policy or government support. One area to step away to another sector in aging for just a moment, just to give an example. One area where this is trying to be done are those who are interested in caregivers having support from their employers. Like employers provide employer provided health insurance, right? If they have so many employers, they have to provide health insurance. And so the argument goes, well, you should also provide support in addition to like maternity and paternity leave and disability, disease, hospitalizations. One of those should be more support for caregivers. And the argument is, caregiving affects work. So if you have support for them, they'll have more productivity and you'll actually lose less money. That's
Right.
the argument. And one of the directions that people are taking is this is just going to have to come from policy. Like we need to have some kind of mandate for employers to include that. And so maybe that's the direction we have to go. I don't know. I'm just giving a few ideas. So no, it's probably not realistic to think this is going to happen just on the individual family level, but it does need to happen somewhere with someone at some level in some way. Um, so we need to be asking, where does that come in? Does that make sense?
Yes. And I totally agree. I mean, you're talking about over 55 million family unpaid caregivers across the United States. A great percentage of those folks who are working full time in addition to their caregiving roles in their personal lives. We're going to break for just a minute. This isn't the end of the episode. There's more to come, so stay connected.
If you're looking for an easy solution to stay connected to your older loved ones, GrandPad is everything you need. It's the all-in-one tablet designed especially for seniors. With GrandPad, you get safe, simple video calling and photo sharing to connect the whole family. The GrandPad utilizes a simple format that allows seniors to enjoy games, music, email, and more. GrandPad comes with 4G LTE cellular service already included, so there's no need for Wi-Fi. Users can create a private family network that allows for secure photo and video sharing. At the core of the GrandPad team are the Grand Advisors, a group of seniors that continually inspire, test, and guide the development of GrandPad. The company has built a platform that empowers seniors of all ages and technological skills to safely connect with family, friends, and caregivers. No spam, no robocalls, only connections with those you trust. The GrandPad team strives to create a world where no senior is lonely or isolated. It's the smart choice to keep older adults connected. Visit our website today at grandpad.net/THOH or call 1-888-904-4723. GrandPad, keeping seniors connected.
Let's switch focus just a little bit. I want to talk about best practice when it comes to communication with healthcare team. You're an expert in this because you have been doing this for a long time for yourself. What are some of the best practice habits when it comes to communicating with your healthcare team?
Yeah. I'll preface the following by saying that the qualities I'm going to mention are skills that people have to build, and you can't just snap your fingers and start doing these things.
Okay.
So I recognize that. I also recognize that some of these skills come more naturally to me. They don't come more naturally to everyone, but I still think that there's this sweet spot for being more assertive and focusing on self-advocacy. There's a balance here. In the social work, we have the passive, assertive, aggressive skill, and assertive is often the sweet spot. I'm more assertive with my physicians and with my care providers, and sometimes my mom also has complex medical needs, and so she and I are always sharing the stories of when we have an interaction with a provider, like, hey, I just went to the doctor, this is what happened. And it's pretty common for her to say things like, wow, you said that to the doctor? I know you can do that. And I'm like, yeah, you're damn right I did. It was a need. I said it. And there's a balance, because if you're too aggressive, then you're going to be indicated in their system as a problem patient, and that's not going to go well. So you have to find that balance, but assertiveness can get you really, really far. I think a lot of people inherently interpret assertiveness as being confrontational. I don't mean that, but you need to step up sometimes and say, hey, listen, it sounds like maybe you're trying to close the conversation down, but I don't think the conversation's actually over. That goes back to your point earlier about, well, my doctor said this and that's that. I'm like, no, it's not that. Let's continue having a conversation, right? So be assertive with what your needs are. And, one strategy that I found that's really, really helpful is I always, ask, okay, what are the ways that I can interact with your office? Let's say I have a question. I don't need to come in. Like, do I need to call your nurses? Is there a patient portal, whatever? And I have the work cell phone number of a couple of my physicians, of a few nurses who are, that I would not have those things unless I pushed for that. And now it's a lot easier for me to ask a really quick question. Hey, I skipped my med last night. What do I need to do about this, instead of having to go in for a visit or waiting 6 months or whatever. I've also pushed for, my cardiologist and neurologist are both dealing with similar issues with me, but they don't communicate with one another. So I might ask, hey, can you call that provider so that y'all are on the same page, and make sure that there's a mutual understanding there. And I mean, but the bottom line is, if you need or want something, ask for it.
Yes.
Ask for it.
And there is a difference. Let's be clear. There is a vivid difference between being assertive and being aggressive. Aggressive is offensive. It's usually ill-mannered. And let's face it, it doesn't get you anything great. But being assertive, using this self-advocacy. So let me ask you something. How old is your mom?
74.
So do you think it's generational that she is
I'm sorry, 71, but anyway.
So do you think it's generational that your mother's a little appalled that you would be so direct with your doctor?
I do think so. I'm always, there's always going to be a little bit of hesitancy when I want to say anything is generational, because I don't want to just paint these broad strokes.
Well, but my mom is 91 and she's the same way. If a doctor says she has to do something, she does it. And I'm like, no, you don't.
I think that there is a little bit of generational stuff there. So yeah, to answer your question, she's 71 and there probably is some of that going on. Yeah.
Yeah. Yeah. Accepting everything as gospel, and you don't have to. Okay. So best practices for communication. Keep going. I think you're on a roll.
Yeah, for sure. So, I mean, for those people who are really uncomfortable with being assertive, what I say is, okay, plan out your visits, right? You have probably several visits scheduled in the next few months or so. Tell yourself you're going to ask one more difficult question each time. Write it down. Say, hey, I really pick out your most important question and work on building that skill of assertiveness. Again, you can't just snap your fingers. It's something that comes more naturally to me. In fact, I used to be more on the aggressive side. I've had to tone it down that way. So we all have to work on it, right? In some way, we all have to work on it. And I completely agree with you. There is a way to convey yourself with confidence and assertiveness without being an a-hole, and without being too demure. There is that sweet spot there. And the other is self-advocacy. I think this is especially important for caregivers because as you and I both know, like the life expectancy, the morbidity, all these negative health outcomes are more likely with caregivers than they are with non-caregivers of the same age. And even within caregiving, there's data showing that morbidity and mortality are higher among caregivers who are caring for someone with dementia compared to caregivers who are caring for other people with other types of issues. And so there are these dynamics. And it's very common to hear people like, I just feel like I have no choice. I think that's another generational thing. When my dad was sick, completely debilitated, I was helping my mom care for that. And her response was like, well, I just have to do this. She didn't have the physical stamina or abilities because of her own health issues to care for him. But it was in her mind, like, this is what I have to do. And there was no questioning of any other alternative. And if it weren't for me, I'm not bragging here. It's just, this is what I'm trained in. If it weren't for me, she would have buried herself in the ground, metaphorically and perhaps literally, if she had just tried to care for him herself. But I got us home health care providers. I contacted the local agency area on aging and did all these other things. And so self-advocacy as a caregiver, like, there's a reason they tell you on airplanes, put on your own oxygen mask first. You are not going to be any good to your loved one if you just bury yourself in the ground with this. If you allow it to drag you down, you have to try to. And I'm not sitting here saying that it's not going to be tough. It's tough as hell. Okay, it is tough.
Right.
But I think that there are more things that we can do with self-advocacy. Draw some boundaries. Be creative. And reach out to people. It's interesting because a common view among those who don't tend to trust government responses or government solutions, they want the problems to be solved at the local level. Let your family take care of it. Let the church take care of it. Let volunteer organizations take care of it. And I don't dislike the ideal of that. I don't think that it works very well in practice, but individuals can do a lot more to help it. I think that there's this. I'm gonna be really honest here for a moment. And I don't know if this is gonna. I don't know how this is gonna sit with people, but I do believe that it's true. I think when it comes to caregiving and other things that require a lot of sacrifice, what's going on in our minds in these situations is two things that are disparate, divergent from one another. One is we recognize that we're exhausted and this is really hard and we wish we could be in a different situation. But I also think that there's a little bit of martyrdom syndrome going on subconsciously. And I think that prevents us from asking for more help. And we need to be willing. If you go to a church, then go to your pastor and say, hey, listen, this is my situation. Is there any way that we could set up a group and they alternate out and they send us a meal each week? I mean, really simple things that you can ask for that I know that a lot of people don't ask for. And I don't think that it's that they don't want the help. I think that there's just this idea like, well, this is my duty and I'm going to take it upon myself. And that's kind of my thing is use the resources that you have available. Be willing. It's hard for people to ask for help. It's just really hard for them to do so. But you have these resources, even if it's like I said, once a week or once every other week, your church members or whatever, fill in the blanks, your family sends you a meal. That can help tremendously. Like, are you kidding me?
Yeah, like that would make
a big difference, and it's not even much sacrifice on their part. We just don't tap into those resources. So assertiveness and self-advocacy can get us a long way.
So I don't disagree with you at all. You were hesitant to use the word martyrdom, but I think that's absolutely true. And there's a lot of psychology. I think there's a lot of emotion, a lot of psychosocial, psychospiritual issues that contribute into that. You're talking about guilt, social expectation, whatever our identity roles are, society's expectation, your family's expectations of what you're supposed to do and what that should look like. God forbid you say, I don't actually want to care for this person. I'm not cut out to be a caregiver. So does that make you a serial killer all of a sudden? It sounds like such a terrible thing. But I think that is true that, and again, not to paint with too broad a brush, but there's some generational obligation, some generational typical behavior, not to stereotype, but this, till death do you part. And if you're with them for 80 years and this person needs you at this point, you stick with it, whether you can actually handle it in a healthy way for either one of you or not. And I think that does come into play. I have seen that with people.
I'm glad I wasn't, completely standing out on the limb. It's affirmational and confirmational to hear that you've seen that a lot as well. Yeah. And you're right. It's a complex issue. There's a lot going on in our minds. Yeah, I'm glad you mentioned the spiritual component of it as well. This is a multifaceted, complex topic. And anyone who says that this can be boiled down to black and white, some simple thing, I'm just like, no.
Oh, good luck with that. Good luck with that. No. Yeah. So I would ask you, with your mom's situation, as a caregiver, her hesitancy to reach out to other resources, what were the influencers behind that? Was it societal expectations, or did she really feel hopeless that there wasn't anything out there for her?
That's a really good question. Maybe I should ask her those questions too. I probably at the time did chalk a lot of it up to generational things. I mean, another factor is my dad has since passed away, died, but his father's still alive in his 90s. And I remember him saying at one point, because he had not prepared as well for retirement, et cetera, but he's like, you know what? Me and everyone else my age did not expect to live this long. And that's true. Their life expectancy back in the day was way lower than it is now.
Right.
And so I think right now we're experiencing a catch up. Like they genuinely, many of these people in those older generations genuinely did not expect to have to deal with these issues because the numbers suggested that they wouldn't have to. And I think that just becomes embedded in every single way, every single thing that we look at in life, if that makes sense. Like that is a deeply embedded mindset. And that's the lens through which you are viewing. Even if logically you know that that's not the case, it's still really hard to realize that we are looking through a certain lens, right? And to put that lens aside and to pick up another one and look through it. And so I think that it's a lot of that going on. That probably does, I think that that helps to explain some of these generational differences that we're seeing. They observed the way that it was really that cutoff point with World War II, honestly, where so many medical surgeries and things were invented on the battlefield because they had to be. And also we realized that, hey, we need to start collecting health-related data on every single country in the world. And this older generation now, my parents and my last remaining grandparent, witnessed these huge changes that happened as a result of World War II. And I think that our cultural and societal mindset has not yet caught up with the technological innovations. And it always goes that way. We can't keep up with the technology and communications technology that's these advancements that are going on, right? I think that's part of it. Does that make sense?
Yes.
It's really you got to look at it pretty historically to kind of see these trends, but it does make sense to me.
Oh, I agree. And you're looking at a 30,000-foot view, which is great. And I think that's a good conversation. And there are a lot of people having that conversation and looking at that. But when it comes to the individual level, they don't have the time or the energy for that.
Well, that's where I think the continuum of care comes in. Families need to be involved. I now go to a lot of my mom's medical appointments with her, and I'm sitting in the room. And some physicians are more amenable to that. Some don't pay me any attention at all. So there's a mindset issue there. But the continuum of care needs to hold the patient and their family members as the central point, and everything radiates out from that. So you're right. This isn't going to happen on the individual level in our current system, but I think about, aspire to a system in which the family members and other loved ones are centrally involved in that care. And that's where I think that it can help out a lot.
So we're getting ready to close, and I want to ask you one other question. If you were talking one-on-one with somebody who's just starting out as an advocate for a loved one who's got a serious illness, what advice would you give that person just starting out?
Yeah, great question. I would take a notebook or do it electronically and think through all the possible resources that you're familiar with. Again, your social groups, your friends, your family, your churches, and connect that to what I said earlier about, hey, can y'all do a meal every other week kind of thing. Think about all the possible resources that you have and start preparing what it's going to look like for you to try to utilize those resources. And I'm not talking about those people have to give blood, sweat, and tears to you. Making a meal every other week for someone isn't that big of a deal, right? And then there's the professional ones as well. Look up your area agency on aging and other such resources like that. If you're in a place where there is a social worker, then say, hey, listen, I want all the possible resources that I can have. Check to see if your employer's benefits include something like, I forget the name of it, but it's an office that say you can call them and say, hey, I have this issue. Can you help me find resources to help with it? It's not employee assistance, but I forget the name of it.
Yeah, but something similar. Yeah.
Yeah, a lot of employees have that as a part of their benefits. Just make an exhaustive list of all the possible things. That's one thing I would definitely say. And then the other thing that I do is I set alarms for all of my medications that I have to take. And if you're caring for someone, just be prepared to do that. Because non-compliance with medication is a really, really common issue. Set alarms. I put things in my calendar and I color them specifically for healthcare. It's brown, and all my other types of meetings are different colors. So every single appointment that I have, even haircuts, dentist appointments, physical therapy, they're in my calendar. And there's no way that I can miss them. Whenever I think of a question that I want to ask my provider, like, oh, this is something I want to ask my cardiologist next time I go. And even if it's 6 months later, I have a note in my iPhone in the Notes app that I write those questions down immediately when I think of them so that I'm not going to forget them later. I mean, all these little practices that don't take much of your time, that are really simple, that's using the tools you already have, like a smartphone or whatever. do these little things, and it honestly can go a long, long way. You know, and I just gave a few ideas. Think about what's going to work for you, but most of these things are just really simple to do.
Yeah, but so valuable, so valuable. Okay, how can my listeners connect with you, find out about where you're speaking and teaching, and tap into the resources you've got?
Yeah, for sure. Thanks for asking about that. I'm very active on LinkedIn. I know not everyone is, but if you are, Jacob Evans Kendall, you'll find me there. And then my website is jacobevanskendall.com, and that's where I focus on my speaking. So those are the two main places to find me. And in my publications section, I put all the podcasts that I'm on and other things like that. So explore my LinkedIn profile and visit my website. And yeah.
Awesome. Well, we will have links to your LinkedIn and to your website so people can tap in, find out where you're speaking. And thank you so much for being on the show, sharing so much of everything that you know and you've learned. I'm really grateful to connect with you today.
Yeah, I enjoyed the conversation. Thanks for asking very pointed and important questions.
Be sure to catch the next episode of the Heart of Hospice podcast. You can find more episodes on theheartofhospice.com, and don't forget to follow us on your favorite podcast platform. You can connect with the Heart of Hospice on Facebook and Instagram, and send your questions or comments by email to helen@theheartofhospice.com. And remember, no matter who you are or where you are in your hospice journey, you are the heart of hospice.
This is the Whole Care Network. Helping you tell your story one podcast at a time.